Hi, I'm Dr. Mian from McMaster University in Canada. I'll talk to you today about why frailty should be dynamic and when we should measure it. So, as we know, multiple myeloma is a cancer of older adults. We know that frailty has emerged as one important key high-risk factor that's associated with poor outcomes, including reduced overall survival and higher rates of toxicity. Now, there are a number of frailty tools that have been developed. Often they're limited by the fact that we're only using them at the time of diagnosis, and a lot of the frailty tools have variables such as age and comorbidities that may be less responsive to short-term change. Therefore, there's a real critical gap in understanding, does frailty change over time in multiple myeloma? Is frailty truly dynamic? And as you can imagine, understanding this is actually quite important because one could potentially escalate therapy to maximize disease control if the frailty status is improving. Conversely, one could de-escalate therapy if the fitness status is worsening to minimize any toxicity. So with this in mind, we conducted a large population-based cohort study using the SEER Medicare administrative database from the United States. We identified patients with multiple myeloma who were older and had received novel drugs. We then calculated a frailty index using a cumulative deficit approach at the time of diagnosis, at 1 year post-diagnosis, 2 year post-diagnosis, and 3 year post-diagnosis, and categorized patients into 5 groups, ranging from non-frail all the way to severely frail. Now, in our cohort, we had 4,617 patients. And what we showed is that frailty is in fact quite dynamic. So when you look at the trajectory of frailty from patients at baseline at the time of diagnosis, at 1 year, 2 years, and 3 years, the majority of patients in fact change the category. So patients can go either from severely frail into moderately frail, or potentially from those that are non-frail deteriorate as well. It was interesting to note in our study that 73% of the patients showed an improvement in frailty and 72% showed a deterioration. So frailty can either both improve or deteriorate over time. Next, we looked at, when is the best time to measure frailty? So we know that baseline frailty is important for prognosis, but we also then recalculated the frailty at each landmark interval, again at 1, 2, and 3 years, and looked at whether it was better predictive of overall survival than just the initial frailty calculated at diagnosis. And so in our study, we were able to show that, in fact, the recalculated frailty index at each landmark interval is better predictive of overall survival than just a frailty that we measured right at the time of diagnosis. We also in our study showed some factors that were associated with the deterioration of frailty 1 year post-diagnosis that included a higher age, Medicare enrollment, as well as combination therapy. So in summary, we've shown that frailty, in fact, is dynamic. The vast majority of patients change their frailty categorization as they get treated, at least in our study, in the first 3 years of treatment duration. We also showed that frailty, in fact, can both improve and deteriorate. Lastly, we show that it's important to remeasure frailty because that may be better predictive of outcomes than just an initial frailty that was done at the time of diagnosis. So we hope that our results will have clinical implications both in clinical trials, where we hope that this concept of remeasured dynamic frailty can be incorporated, as well as in clinical practice, where we're not just measuring frailty at one time point, but are measuring it at different disease time points to really tailor our treatment. With this, thank you so much, and I hope everyone has a great ASH conference.